everyone, and welcome to the BSMA Speciality webinar. If you could just actually enter in the room, just mute yourself, and we'll get started soon. We're just going to wait around just a little bit, just to allow people to join the chat, and then we'll get started soon. So yeah, if we could just make sure that you remain muted, and then we will go through the details of how the session is going to go. But just to introduce myself, so my name is Dr. Sumaya Gerhan, or Dr. Sumaya Gurhan, shall we say, and I am a radiology registrar based in the West Midlands. And with us today, our first speaker is here, which is Dr. Fatima Yusuf, who's a psychiatry trainee based in London. So we will have the psychiatry talk first, and then thereafter we will have the internal medical trainee doing his talk, which is Dr. Umar Darir, and he'll be joining us as well shortly. Just in terms of some information, so in terms of Q&A, I will be sharing my screen shortly regarding the QR code that I want you guys to look at. And this is the method that we'll be using for questions and answers. And I will be asking the speakers your questions. In terms of feedback, if you give us feedback, which I will put in the chat, you will then get a certificate of attendance, which is really good for showing your commitment to the speciality of your choice, which we all had to do when we were trying to apply for our fields. So first thing what I will do is I will start screen sharing, and then we will go from there. Okay, so this is the slide. So if you could just, either you can use your phone and just scan the QR code, or you can look at this link, www.slido.do, and that's the participation code. Don't worry, I will be putting it in the chat as well. But I'll be giving you guys just a couple of minutes to look at that, and then we'll go from there. Okay. We'll start in literally just a couple of minutes' time. Okay. Just for those who are joining, if you could just please look at the QR code here, use your phone. This is how we will be asking questions to our speakers. I will be putting a feedback form in the chat for you to fill out at the end. If you fill it out, you get a certificate of attendance as well. But thank you so much for joining us. Okay, so I'm going to stop screen sharing. Don't worry if you haven't got it yet. I'll put it in the chat as well. Okay, so Dr. Yusuf, if you please screen share and introduce yourself, and you may begin.
Hi, assalamu alaikum everyone. Yeah, I'll just share the PowerPoint. Good. Can you guys see that?
Yes, we can see it. Thank you.
Okay. So hi everyone, my name is Fatima. I'm a CT1 psychiatry trainee working in East London. So hopefully today I'll talk to you guys a bit about the psychiatry application process in the UK, a bit about my role, my typical day as a trainee, and then hopefully answer any questions that you have. Yeah, so feel free to just ask me anything. And if you need to after the talk as well, I'm happy to share my email for any further questions. So to start with, I'll talk a bit about the psychiatry recruitment process. So I know COVID was a bad time for a lot of us, but one great positive that came out of COVID was that the way that the psychiatry people do recruitment now has completely changed. So in the past, you used to have to apply, you'd have kind of an interview where you'd have a portfolio that would be scrutinized. You'd have to kind of, answer questions in that interview. I think it was a panel form. You'd also have to do the recruitment exam. But since COVID, so since I think about mid 2020, this has all been scrapped and simplified. And I've spoken to the psychiatry admissions team, and they've reassured me that it's going to remain the same until at least February 2024. So that means that the next at least 3 rounds of applications to join. So this the February intake that's applying now, I believe, the August intake 2023, and then the February 2024 intake as well, they all will be just the exam. So that means no more interviews, no more portfolios. You'll be sitting the MSRA, which is sat by multiple different specialties. I'm sure you've all heard of it. And you'll be just applying online, really. So, I mean, overall, it's kind of great news for us. I guess the negative would be for somebody who doesn't like exams, and that you might have enjoyed being able to kind of express yourself and talk more at the interview. So there are some cons there for some people, but I think overall it is much more simplified, and it means that actually, even if you decide to apply for psychiatry last minute, you haven't got massive gaps in your portfolio with no kind of like psychiatry specific stuff, because it's all gone. So to talk a little bit about the application process. So you apply similar to all the other specialties on Oriel. So you'll register on there and you'll fill out a basic application form. There wasn't really much in particular on there. There was no kind of open text areas for everything. Was kind of just your personal details, what you used to, the jobs that you've done so far. You put in 2 references and you apply for a course psychiatry training. They've also started a run-through training for ST1 child and adult psychiatry. That means that basically you will go straight into specializing into specifically child and adult psychiatry. And then the other applications is for core training. And the way they've done it now actually is that they've made that all into one single application. And what you'll do is when you're ranking jobs, if you want to do child and adult psychiatry, you would rank those higher than the core training ones. So it's quite nice. You don't have to decide straight away which one you want to apply for. You just apply for everything. So once you've sent off your application, if you meet the basic requirements, they call it long listing. So you'll be sent an email saying that you've passed long listing and that they'll advise you to book your MSRA. You'll sit that exam. And then after that, you'll be asked to complete your preferences. So that means that you'll be ranking the job posts throughout the country. For us, you don't apply for a specific job similar to other kind of areas of medicine. What you would do is you kind of ranking based on areas. So, you have Northeast London, South London, and of course you've got the Midlands and everywhere else outside of London that exists as well, of course. And then after that, you'll get your offers and you'll respond to your offer and accept. So it is definitely a very simplified application process, which is, great for us, really. So the eligibility criteria, so this is just from HEE. It's basically very basic. Essentially, you literally just have to be kind of like a qualified doctor, so fully registered with GMC, so kind of completed your F1, have 2 years of experience working. So that basically means that you've done your F2 if you're based in the UK. So essentially from medical school for work for 2 years, and if you are kind of a foreign graduate, working in any kind of role for 2 years, be eligible to work in the UK, speak English, and have the foundation competencies, which is basically kind of F1, F2 level. There's not really any strict requirements, really, and there's not any requirements specifically for psychiatry experience. Especially, I think that was something that used to be asked before in the interviews, but I mean, with that gone now, there's not really any preference for that. But of course, I would advise everybody to get a bit of psychiatry experience before applying, just to guide your decision. If you don't have a job in psychiatry, this could be a taster week, or just anything really would be great to do. So just a little bit about the exam. I'm sure you guys are all aware. It's not a psychiatry specific exam. It's used by many different kind of areas of medicine. I think it's like, GP, radiology, obs and gynae. During COVID, a lot of different areas of medicine have now taken on this exam. It's computer-based multiple choice. You just sit it usually in a Pearson VUE. Now I think you sit them in person. Before they were online during COVID. Again, the result of your MSRA is now solely used to rank you. So you'll be ranked against all the other candidates, and that will basically impact if you get an offer and also which job you get. So what area you get from your rankings. It's broken down into two parts. So the first part is the professional dilemmas paper, which is similar to kind of SJT. So, you know, you're in a kind of a common scenario working at an F2 level. Out of there's 50 scenarios that you'll go through, and out of those, 8 of them are pilots, so they don't contribute towards your final result. And then you have the problem solving questions, which is basically kind of like F2 level medicine. It's not psychiatry specific, so you'd have to revise everything again, unfortunately. Yeah, so it's basically, to, I would say, a final year standard. I used MCQ Bank and PassMed. I finished most of the questions on those two, and I did quite well, so I think that is more than enough to do. So yeah, just a bit more information. So in the professional dilemmas section, you basically got 2 different types of questions. So you've got ranking questions, which is basically 5 actions that you would do in response to a scenario, and you'd rank them from the most to the least appropriate thing to do. And then you have multiple choice, which you're basically picking 3 out of 8 options that you would do for an action. A useful tip that someone told me is that ranking questions are or questions, and multiple choice questions are and questions, meaning that in the ranking questions you're doing this or that. So you don't think of the options as together, you're doing one or the other. Whereas in the multiple choice, when you're picking the 3 scenarios, you have to think of them as kind of 3 things that you would do together. So if 2 of them sound very similar, you know, if it says something like talk to your consultant or talk to your reg, probably one of them is wrong because you're picking the 3 things that you all do together. Yeah. And then, yeah, so the clinical problem solving area, so that's again to kind of an F2 level. They've got single best answers and extended matching questions, which I'm sure we're all used to. It covers basically a bit of everything. So investigation, diagnoses, emergency treatment, management, recognizing emergency conditions, prescribing. And yeah, again, I used PassMed and MCQ Bank, and that was enough really. And I guess the good thing about a lot of different specialties using this exam now is that you can apply for more than one specialty if you're not sure yet, and see what happens, and not have to sit too many different exams. So yeah, so that's it really for kind of the application process. It really is quite simple now. It is just that one exam, ranking, applying on Oriel, and that's it. Getting your 2 references in. They do contact them. And there's not much, and they don't need to be psychiatry specific references, could be anybody, previous consultants you've worked with. So there's not much else really about the application process, but if anybody has any questions at the end, do let me know. So I'll just talk a bit about kind of like life as a trainee, the training program, and yeah, then I'll do some questions. So I'm currently a core trainee. I'm just finishing my first year of core training. Core training lasts for 3 years, and then after that you have you know, your registrar training, and then that lasts for about 3 years, but most people kind of extend it for slightly longer. Throughout core training, you basically do 6-month rotations. Excuse me, so that can be kind of there's certain areas that you do have to cover. So you do 2 general adult jobs, you do 1 CAMS job, so that's child and adolescent mental health, or you can do a learning disabilities job. You have to do an older adults job. It'll be a mix of community and inpatients, and then you'll also get the chance to do any specialty jobs that you're interested in. For example, forensics, forensic psychiatry, so kind of, you know, people in the criminal system as well. Perinatal, home treatment team, psychiatry liaison, so working in the physical health hospital. So I mean, there's a lot of diversity there. I'm currently on a general adult job. I finished my older adults job for my first rotation of CT1, and my next job is forensics, which to be honest I'm not looking forward to, but there's only so much choice you get sometimes, because I got my first choice jobs for my first 2 rotations. So I'm going to be working in forensics and going to prisons. Don't know how I feel about that, but I'm sure it'll be interesting and I will learn a lot. So during your core training, you'll sit some exams, and that will be to become a fully registered member of the Royal College of Psychiatry. So it's Part A, Part B, and CASC, which you do at the end, which is an OSCE. You can sit them at any time during your training, and sometimes people even do it after they finish their core training. But you know, the longer you delay it, the longer you're waiting to be a fully registered member, and without finishing those exams, you can't become a registrar. You can't, you know, start sectioning people and doing kind of those kind of jobs. So it's important to get them done. Generally, they're advisable to do 1 a year. So I've just set my Part A. it is quite hard. It's very kind of neuropsychiatry heavy, a lot of neuropsychiatry heavy, and then part B is quite statistics heavy, but you know, it's things that we just need to get done. Psychiatry, honestly, they're one of the most flexible and supportive areas. I know parents have had a really, you know, nice time and get a lot of reasonable adjustments. Now they've introduced a new thing last year where you can go part-time for no reason. In the past, you had to justify going part-time and saying, you know, I've got children, I'm a carer, I'm stressed, I've got physical health issues or something. But now you actually need no reason to at least go up to 80%, which I think is really nice, because for some of us, you know, it might not work for us to be full-time. So there is a lot of flexibility there. At the end of each year, you'll have your ARCP. The competencies, to be honest, aren't too bad. It's similar to what you're used to as a foundation trainee. So you're going to have certain requirements, so kind of a case-based discussion. Mini ACEs are similar to mini KEXs, and ACE is kind of a fuller mini KEX, you know, multi-source feedback. You will have to do certain psychiatry, they're all psychiatry specific, but things that you haven't heard of before, which is kind of a long case and a short case in your CT 2 and 3, which you're basically delivering psychotherapy to somebody. Apparently it's a really great experience. I haven't started it yet. So there, it's not too bad really. ARCP for me has gone by and it was fine. They're quite flexible again. If you don't get the competencies done the first time, they give you a couple of weeks to try again, and they're not too harsh. So my current job is a general adult job. So it's based in East London. The good thing about working, if you guys are in London based, East London Foundation Trust is one of the best for psychiatry. I would highly recommend anyone applying for it. They're so supportive, diverse, really just open-minded people. And their jobs are kind of mixed. So you're not fully in the community or fully inpatient. So mine at the moment is 80% inpatient, 20% community. A typical day is kind of, you start the day with something called a safety huddle, which is similar to a board round on medical wards, where you talk through all the patients and identify anybody who's unwell and needs kind of any urgent care. You do ward rounds, you do your regular ward jobs. There is a lot of physical health on the inpatient jobs, annoying things, ECGs, bloods, because of the heavy medications we give people. You do, you know, your regular on calls, but in my whole 6-month rotation, I've had 7 nights. So it is a nice rota. To be honest, I think I've done, in a 6-month block, I did 3 weekends and 7 nights. So you do have a long day every now and again. But I guess the pro is it's better than getting paid base rate as a doctor, SHO. And yeah, clinics, you know, kind of typical. You'll see new patients, you'll follow patients up. It's really interesting. And also one of the great things about psychiatry is I've never seen a kind of area of medicine which has so much protected teaching time. Every Wednesday afternoon without fail, you kind of leave at 12:30. You've got protective teaching from 1 to 5. During COVID, it's been online, which has been great. So you get to go home, but before it was face-to-face. And again, that was nice because it was quite social. And I think that's across the UK, has that kind of Wednesday afternoon. And also when you start revising for your exam, you have another afternoon off to attend teaching. So essentially a day a week you're in teaching, which I think is great. It just, very protected. So a little bit about why psychiatry and why I chose it. I think I've always been really interested in psychiatry. In medical school, I was kind of always interested in psychiatry and pediatrics. So I always said maybe I'll go into child mental health. But actually now I think I just realized actually you're fully interested in psychiatry. You're just a bit scared to say it because, you know, people always say that psychiatrists are weirdos, or, you know, they analyze people, or all these kind of stereotypes of a psychiatrist. I feel like I maybe hesitated from fully committing early on. But there is just nothing like psychiatry. I mean, it's just so unique in itself. If you haven't had the experience of it, I would highly recommend getting some experience. I mean, walking onto a psychiatry ward, it's just so different from anything you'll ever experience. You've got people there who are just acutely unwell. The majority will be, you know, psychotic, manic. You'll have a few kind of depressed, suicidal patients, especially if you're kind of working in a diverse area, which again, I would recommend. Cities, they are definitely have more unwell patients, and just, you know, you'll see people who are from all walks of life and you learn a lot about them. You just have so much patient contact, you know, they are constantly in your face. When you're in your office, they're knocking on your door trying to talk to you. You get to know them on such a deep level. You find out why people are the way they are. You know, there's something that led someone to becoming so mentally unwell. You find out about everything, their childhood, their families, their relationships, their spirituality, just them as a whole. And I really do love that. I feel like we see the bigger picture as psychiatrists, and you're more than a doctor when you're a psychiatrist. You're also thinking about, you know, their home situation. You're almost a social worker. You're almost a lawyer, because you're thinking about all the legal status of everything. And I just think it's just, there's never a day, there's some days where I might be stressed, but there's never ever a day that I'm bored. There's always kind of someone to talk to, a patient that needs help. Their stories are so interesting, and just, I think, yeah, just the things that people go through in life, it's very humbling to be a psychiatrist. You realize that most people live, you know, a lot of us have had lived lives that, you know, becoming a doctor, we've been privileged in that way. A lot of people have lived lives of, you know, terrible lives where they've been not looked after, you know, gone through horrible situations, and you just have that appreciation for life, and just really just helps you just understand people. And yeah, I love every second of it, honestly. It's very supportive environment, so it's very much an MDT approach. It's different to other areas of medicine. You will have kind of very senior nurses who are more involved clinically. I know that in, you know, medicine, you know, when I say medicine, I mean kind of just gen med. When you're on the wards, kind of matrons and these kind of people, they are not clinically involved anymore. They end up going to more the paperwork and pushing for beds and all this kind of nonsense. But actually in psychiatry, it's an MDT approach. In those morning safety huddles, you have occupational therapists, you have so they're called like social therapists, you have kind of bilingual support workers, consultants, nurses, matrons, everyone's talking and everyone's kind of listened to. Yeah, and also there's a lot of support as a junior doctor. So we have protected supervision. So for an hour a week, basically, you meet with your consultant supervisor, and that's your protected hour to talk about anything and everything. This has to happen every week, otherwise it should be raised. You can use that hour to talk about anything, any difficult patients you've had, any kind of, because it is, you know, it is tough in a way, because you see so many emotional things every day, and it's good to have an outlet. Every week during teaching, you have Balance Group, which is basically a protected space for core trainees to talk with a psychotherapist consultant, also kind of guiding the conversation, where somebody will present kind of a difficult case or a patient that's been on their mind and worrying them. Again, it's a place to kind of, I use it as a place to like kind of like rant and almost cry sometimes, and it is just very supportive. I don't think there's ever been a day where I felt totally alone in a decision. There's always someone there to kind of, yeah, support you, really. And also I think it was important for people like me and people like maybe some of you guys, you know, I'm Muslim, I'm Black, I'm female, I'm a Londoner. We are overrepresented in a crazy way, you know. Black people are, I can't remember the exact statistics, but we're way more likely to be sectioned, detained, have IM injections, be put in seclusion, which is an area where basically really, really unwell patients go. We're more likely to go into intensive care, psychiatry intensive care. So it's important for patients to see people like us there. Lots of my patients are Somali working in East London, and they are happy to see us. And I think we need to have more people that are culturally aware. You know, even today I'm seeing a patient whose delusions are all regarding black magic, and it's stopping her from eating. So it's important that, you know, they see somebody who understands the religion, who looks like them, who wears hijab, and they are saying, you know, no, this is illness, this is, you know, with the help of kind of, the great thing about working in East London is we really work closely with the sheikhs and the imams, and they kind of come on the wards and talk to patients about what they're thinking and explain mental health, and it's just an amazing environment for that stuff. And you as a doctor being like, you know, I think you've got schizophrenia, I think you're unwell, this is not, you know, religion's important, but, you know, being able to say that and not being kind of a white male saying that to them is powerful. So I think, yeah, you have a lot to add just by being you and being present and visible. And finally, I feel like psychiatry for me really plays to my strengths. I think I'm I'm extroverted person. I get energy from kind of being around other people. I enjoy being around, I don't enjoy things that I do in solitude. I like to be around other people. I'm quite empathetic, and I feel like I like to get to know people, and yeah, just in my field sometimes. And I feel like that, yeah, plays to my strengths a lot, and is half the reason why I enjoy psychiatry so much. yeah, that's it really. If you've got any questions, feel free to, I don't know if Samaya wants you to use the little device.
Thank you so much. Everyone, if you could just put any questions you have into Slido, and then I can ask Dr. Yusuf on your behalf. Whilst people are doing that, Doctor, if you just stop screen sharing. Is it not letting me? Yeah, amazing. So that was amazing. Thank you so much for that talk. Especially, I loved the bit about why you chose psychiatry and all of the different facets and how varied psychiatry is. So thank you so much for that.
Okay.
Honestly, it's really, really interesting. So I'm just going to give people just a minute if they have any questions. If not to worry. We can then go on to the next speaker. Yes, it's quite interesting about, especially in terms of just the representation aspect in psychiatry, how important that is. So, but that's really fascinating.
It definitely is. People are just happy to see you there. You know, whether it be like, as a Muslim, as a Black person, as a Somali, like they're just happy to see you, and they do listen more.
Amazing.
And now some of my consultants use me as a prop. They're like, oh, Fatima agrees with me. You know, look how she's Muslim.
Look
she
at
agrees with me too.
Look what representation.
Yeah.
But Dr. Yusuf, there's no other questions. So thank you so much. We're going to move on to Dr. Umar Dirir. If you could just, I'm trying to find his screen. If you could just put your camera on. And thank you so much. Okay, so I'm just going to introduce the next speaker. So it's Dr. Umar Dirir. He is a IMT trainee. So bear with me just a second, I'm just going to pin him. Yeah, so he's an IMT trainee in the North. So if you could screen share, introduce yourself, and then we can get started.
Hi. My name is Omar. I'm an IMT 1 in Sheffield. And bear with me.
No problem. Omar, also, if you could just speak a bit louder, just because the audio is not the best.
Oh, sorry. Okay, can you hear me now?
We can hear you. It's just quiet. That's all.
Fine.
You may just have to shout. That's all. Yeah, we can see your screen.
Right, sorry about that. Right, my name is Omar. I'm one of the IMT 1 trainees in Sheffield. I'm just finishing my first year. Just so I know how to tailor this talk, can I just check with people are we medical students? Are we hoping to get into medicine? What's the general demographic or spread?
I'm not too sure exactly about who's in this chat today, but so far we've got someone that said they're an F2, we've got a medical student, an F2, a medical student. So generally medical students and
okay.
Yeah.
Well, that means everyone sounds like they at least got a good base knowledge to begin with. I don't have to, I can tailor it accordingly. So IMT, internal medicine training, it replaced CMT, I think maybe 3-4 years ago now. And it's the main pathway into medical specialty training. I'll explain what medical specialty training is in a bit. I'll cover what the application process for IMT is, giving a bit more of an explanation as to what IMT day-to-day is and on calls, just answer any questions you've got, maybe give some advice about potential interview, portfolio pitfalls, and just how to prepare, especially in medical school, foundation training. You can really set yourself up to score a lot of points and get a really good job at the end of it if that's what you're aiming for. So as I said before, I'm an IMT 1 in Sheffield. I've just finished my first year. I'm going into my second year, inshallah, in August. I went to Sheffield Medical School. I did F1 and F2 in Merseyside and just come back again to continue my further training. I've got an interest in cardiology, and that's why I've gone into IMT. I had an early interest in cardiology, and I just tailored my portfolio from the beginning just to get as much points as possible to get the jobs I want. You don't need to be just interested in cardiology to do internal medical training. Internal medical training tends to cover a lot of the stereotypical medical jobs that you thought of before you got into medical school when you were younger. So if you're interested in gastroenterology, if you're interested in endocrinology, diabetes, care of the elderly, respiratory medicine, even some of the more niche topics such as oncology, rheumatology, things like microbiology, infectious diseases. So you could do absurd things like aviation and space medicine, sports medicine, just by doing a few years of this. So you finish your first 2 years, and then if you want to do a group 2 specialty, then you can exit training and go straight into specialty training, or you could do a third year and go into some of the more classical medical specialties. But I'll explain what makes a group 1 and group 2 specialty a bit later on. But getting into the job is the first step. So if you've done foundation program, you'll have been familiar with Oriel, and IMT will be through Oriel as well. So you'll apply through Oriel, you'll find the vacancy you want, you'll score yourself with any evidence you've got, and then you'll answer things like simple white space questions. So I did my F1, F2 in Merseyside, and then I did an F3, but I applied during my F2 year as well because I was undecided whether or not I wanted to do an F3. So I was the last, during that application cycle, I was the last cohort of people to do a proper face-to-face interview before COVID happened, obviously. And then I applied the subsequent year and did a online only application as well. So I've had some experience of both worlds, and I suspect that as the world opens up a bit more, people are going to start going back to classical face-to-face interviews, so I can give a bit more experience of that. But over those 2 application cycles, these specific white space questions were on there. So it was things like examples of reflection, MDT, teamwork. So you just explain examples, particularly in F1, F2, maybe in medical school if you were part of a society, of things you've done, how you work together in a team, and you score big points for those if you come up with a quite nicely worded answer there. And then obviously the basic ones, such as like why internal medicine, what have you done to prepare for internal medicine, and any interests or hobbies you've got outside of it, just to kind of provide a holistic picture. So these are things like sports, any instruments or anything like that you partake in. But the self-assessment criteria part is really where you get the bulk of your points outside of the interview. So here you would get a maximum of 6 points for any undergraduate degree in addition to medicine. So if you intercalated or did a master's degree during your medical school years or before you got into medicine, you could guess a few points for that. I know in my year of med school, there was someone there in the year below actually who had a PhD, so they were already a doctor, and they would have got 6 points for that as well. Additional achievements are things like scoring winning awards in medical school, getting in the top 10%, essay prizes, things of that nature. And then presentations again. So the more prestigious the event, the more points you would get. So if you were to present at an international or national conference a couple of times, you would get 8 points. If you did a local poster presentation in your medical school, you'd get 1 or 2 points, and everything falls in between those two. The same with qualifications. Again, the maximum 8 points seems, I'd be impressed if anyone got 8 points. You need 2 randomized controlled trials that you're the first author on, and a lot of people will go their entire careers without doing that. But if you were to intercalate and do a project that you can get a publication out of, you can quite easily get 4 to 5 points, 6 points maybe on that. And then teaching experience, this is the bit where I think you could, if you're quite smart and plan ahead, you can score a lot of points with minimal effort. If you just get a couple of your friends together, come up with an idea of how to teach a couple of medical students or people interested in medicine, and just do it over a minimum of 3 months. So there's a criteria of what you need to do and how many people you need to recruit, and you can get 6 points for that. And so, for example, I did a medical student teaching program when I was in F1. So we would come in about 8 a.m. and do an hour's teaching before work to the medical students with various cardiology topics. And it was me and 3 other F1s, and I recruited them. And when they applied, I'm sure they wrote down somewhere that they recruited me. But we all got maximum points for that. And because especially if you go to a district hospital, not in a tertiary centre, so one of the bigger hospitals, if you go to the smaller hospitals, there's a lot of scope to do that with the medical students, because there's no formal teaching programs in place half the time, and they're quite eager to involve the doctors in any sort of teaching program you can come up with. So there's a lot more scope there to get points easily with a few months work. Same with the QI project, you can get a maximum of 8 points for the QI project. They're quite big on QI projects in medicine. It shows that you're engaging with the services and helping improve them. And if you do full 3 cycles, you can get 8 points, which is more than most of the criteria. And then same with the leadership. If you were to say one of society and medical school, you would get quite a few points there. So I mean, the overall point there is, if you look at if you're interested in medicine, have a quick look at what the self-assessment criteria is. They change every couple of years or so, but the overall point spread doesn't really change significantly. And if you plan ahead, you can get a lot of points. So a full QI project will be worth much more than a PhD would. So if you can, which is obviously a few months worth compared to 3 or 4 years work. So you're just planning ahead and trying to get the right amount of points. So this is something I found out just a month or so before my interview. You need to have a portfolio, a physical portfolio. You need to get a binder, like a nice one, and then put all your information in there. So your GMC registration, your degree, some sort of ID, your signed competencies from F1 to say you're qualified to enter higher specialty training or core specialty training. Anything relevant to your self-assessment. So if you scored yourself on a publication, you need to print off the publication and put it in your folder. You need to print off any evidence of your teaching, any evidence of leadership posts, things of that nature. And then anything at the back that you want to include as well. So anything that you'd be exceptionally proud of. So patient feedback forms, tabs, DOPS relevant to your specialty. So I cardioverted someone in F1 and I got that as a DOPS, so that was a pretty cool DOPS to have. Obviously, other DOPS are less exciting. Maybe you wouldn't want to include them. So if you did it for like a PR exam or something, you probably shouldn't include that, but put it in a binder, put a contents page at the front, clearly, some nice dividers in between, and just the nicer it looks, and as long as you know your portfolio in and out, back to front, you know everything, then you're setting yourself up quite well for the interviews. So the portfolio station is usually the first station you start off with in the interview. There's 3 main stations. There's a portfolio station, there's a clinical station, an ethical station. Your portfolio station is the one where you get most of your points, and quite easily, as long as you know what is in your portfolio. They're going to only ever have like 10 minutes or so to read through your portfolio before you walk in the door. So you're going to know a lot more about your own portfolio than they will. So they'll ask you some questions about why you've scored yourself this, and you'll just explain, you'll tell them where the evidence for that is, and you'll just elaborate on some of the things that maybe you couldn't score points for, but you think are relevant. So patient feedback forms or tabs or DOPS that were relevant, or things that you've already scored yourself for in one thing, but say you did more than one teaching, and you want to talk about the other teaching as well, you could highlight that there. The next station is the clinical station. That's a brief clinical scenario. I wouldn't stress too much about that. They're going to be aimed at your current level. So any F2s, it'll be aimed at your F2 level. So in IMT, you'll only ever really be an SHO up until IMT 3. So you should be able to do a basic A to E assessment. So anyone who's come in, say septic, you really need to just say a few buzzwords about fluids, antibiotics. If they tell you the BM's 46, then mention that you'd give them insulin. If they're having seizures, you go down your status epilepticus pathway. As long as you can show a basic competence in assessing an unwell patient until you can escalate it to someone else, or until there's other people who can support you there arrive, then you should score your maximum amount of points. And it's just making sure you don't trip over your words and just kind of come across as someone who would be quite calm in an emergency in an arrest setting. The ethical station is a bit more awkward to explain. It's quite similar to anyone who's preparing or done the SJT. It's a lot of that similar stuff. So they'll give you scenarios of, say you smell alcohol on the breath of your consultant, what would you do? And you have to just kind of go through the stages of, I discuss it with them, I'd flag it up to my supervisor, I'd flag it up to the registrar, flag it up to one of the other consultants, and just kind of the same with the other colleague who's persistently late, what would you do type of scenario. You just kind of explain sensible thoughts about how you would discuss it with them, then escalate it to someone on your team or on your ward, and then escalate it to your educational clinical supervisor, and escalate it to their clinical supervisor. It's just going through that kind of motion of just ticking those boxes so you can get those easy points. And I'd be aware of a few of the key buzzwords and laws related to medical practice. I can't remember them. I had to memorize them for the interview. So it's things like the Mental Health Capacity Act, things like the 4 principles of fairness, justice, things of that nature. If you just kind of go over those things very briefly, just so you can kind of mention them and see if you can score a few points. Those ones, I think in that one, I don't think it's as strongly as the mark scheme is probably a bit more fluid. It's much softer. If you just come across as someone who's well-spoken and knows what they're talking about and quite sensible when they're thinking, you'd score a lot of points. So when I did my interview, I just remember I was saying a bunch of words, and then eventually they just started nodding their heads and agreeing with some of the stuff I was saying, and just kind of realizing, okay, yeah, just say these buzzwords and you can get some points there. So once you do that, you'll get to the shortlisting stage. So the reason why I harped on about the scoring system is because medicine classically used to be not very difficult to get a job in 5-6 years ago, as long as you were willing to move to other parts of the country. But I don't know, something's changed in the application process. They've opened it up to international applicants a lot earlier in the process. So there's kind of, plus COVID's happened, so there's been a spike in recent years in applicants. And this is the last 2 or 3 years, and now we're getting the first stories of people not getting jobs in medicine, getting rejected completely. And when I applied last year, there was 3,500 people who applied. It was much more than the jobs that were available. It was about 1,500 jobs. So you do need to score quite well. And you need to, especially, I mean, if you could get a job, but you want to make sure you get a job somewhere you like. You don't want to be stuck in a DGH for 2-3 years at a time. You want to be able to get some specialties that you're interested in. Obviously, ultimately, the whole goal of IMT is to try to get a specialty related, or to get experience in the specialty that you want to apply for after the 3 years or the 2 years. So you want to make sure you get a good track that gives you the opportunity to do that, to build up another portfolio for your registrar applications. So just planning ahead and making sure you do well in this interview, so that the next interview is a lot easier as well. And then you can see there the competition ratio is just above 2 for the first time ever last year, and I think it'll probably stay above 2 as well this year. Looks like there's a lot of applicants this year, so it's just to be aware of and planning ahead if you are interested in medicine. It's getting a lot more competitive. So in terms of what an internal medicine trainee, so you've got the job, what are you expected to do? Day-to-day work is actually not too different to, say, an F1 or an F2 in medicine. Initially, you cover the wards, you do the ward round, you do your on-calls, or you cover a few wards. You're given a lot more independence in your on-calls, so you will, if you're in a DGH, you'll be expected to act up sometimes. If there's a rota gap, you'll be doing the acute take. At least one of your 3 rotations has to be in care of the elderly as part of the track, because of the general demographics of this country. They want everyone to be experienced in elderly medicine. And then you'll have to have completed part 1 of your membership exams. There's a slide further on later on where I can discuss that a bit more. The second year is a bit more interesting. Apparently, I haven't got there yet, but you'll be doing your outpatient clinics a lot more. So in the course of 3 years, you need to attend at least 80 outpatient clinics, and they say a minimum of 20 per year, but the majority should be done in IMT too. So a vague way of describing it, but essentially you should be aiming to get 2 or 3 clinics a week there. Now, sometimes if the consultant's quite nice, you get to run your own clinics. If they're not, you'll just sit in the corner. But the whole point is to get used to just seeing patients outside of a ward setting, getting used to contacting GPs, getting used to setting patients up to do blood tests and investigations outside of hospital, and just booking them in for further things. So just getting the basics right for when you are a registrar and you start doing your own clinics in a more formal setting. By the end of your second year, you're expected to finish all of your exams. So your part 2, and then at least attempted PACES. This is a new rule. In the past, you should have completed PACES. PACES is kind of a giant OSCE, and you just need to, at the end of this OSCE, you just need to be able to explain what the diagnosis is and how you would manage it in a lot more detail than you would be expected at the end of medical school. But it is ultimately essentially an OSCE. You just kind of examine patients. There'll be a gastro station, a cardio station, respiratory station, and just be able to figure out what the disease is and being able to explain to them how you would manage them. IMT 3 is the new one. This is the one that they changed the entire program to include this third year in there. And here you'll be running the acute unselected take. So you'll be dealing with patients. You'll be dealing with the take team, and you'll be allocating patients to your juniors, and you'll be accepting patients from A&E. You'll be leading cardiac arrest calls. You'll be expected to lead cardiac arrest calls. And this is your first experience of the med-reg life. So in the past, people would go into SD3 and have to learn how to be a specialty trainee in whatever specialty they chose, and learn how to manage a med-reg life on call. And it's people really struggling with doing both those two things, which are quite difficult in and of themselves separately, but having to do them both at the same time. So this is just giving you a year runway of just learning how to be a med-reg first, and then you'll start SD4 and learn how to be a specialty trainee after that. So the membership exams, so the MRCP Part 1, which is the one that I've just finished back in January or February, it's a lot quite similar to medical school. It's to do with leukotrienes and cytokines and knowing the cranial nerves and very specific questions about antibodies that you tend to forget. So you leave medical school, you forget all that information, you don't have to be a doctor in F1, F2, and then you have to learn all that stuff again for this exam. The subsequent exam is a lot more clinical. You're expected to interpret ECGs a lot more thoroughly, CT scans, chest x-rays, things of that nature. And even the questions that aren't involving imaging will be a lot more to do with the management of patients and clinical signs. And then your Part 3, your PACES would be your OSCE situation where you show that you can thoroughly examine a patient and come up with a diagnosis. These are expensive exams. They cost about $450 each, but you get your tax back on them. So I don't know what that is. That's about 150 to 100-ish pounds per exam. You can get claim back, which is long and convoluted. And then you have to pay your membership fees for your Royal College. This is the same for any specialty you go into. And that's I think I paid £380 total to get in at the start of the year. Again, you can claim your tax back on that, but it is quite a chunk of money there. At the end of the IMT 1 and at the end of the IMT 3, you can go into dual training in your group 1 specialties. So this is your classical specialties, I could consider them. So your care of the elderly, your respiratory, neurology, renal, rheumatology. So these ones you will dual train at least for the first couple of years. And some specialties like cardiology, you only have to do general medicine for the first couple of years. After that, you're expected to specialize in just purely cardiology and whatever specialty in cardiology you want to do. But most of the specialties you would continue with general medicine for the entirety of your career, helping with the post-stakes and acute medicine, things of that nature. The group 2 specialties are some of the more unusual specialties. These are usually the less acute specialties. They're mostly based in outpatients departments, so things like immunology, clinical genetics, medical ophthalmology. These things you're not expected to have an on-call service. You're not really expected to be in hospital as often with a ward, which is why you don't do a dual training with Gen Med. Which means that at the end of the second year of IMT, you can actually leave IMT entirely and just apply for your specialty. But I can't comment too much on what you would need because they all have oddly specific things that they want you to have for your requirements for these things. So if you are interested in anything in that list on the right there, you'd have to kind of look into that and just make sure you can plan ahead of it. Things like hematology and dermatology are quite popular, just for the basis of the work-life balance is a lot nicer than anything in the group 1 specialties, where you're less likely to have out of hours on calls or be called in in the middle of the night to come and review patients. That's a really quick overview of what internal medicine is. I'm happy to answer any questions you've got about any of that.
Thank you so much for your talk, Dr. Omar Direr. If you could just stop screen sharing, and then we can get started with the Q&A bit. Guys, if you just make sure you just put your questions in the slide there, and then I can ask you questions. But yeah, that was really, really good overview. Thank you so much for that. Okay, so, oh, actually, sorry, that question is for psychiatry. Right, is Dr. Fatima Yusuf? I don't think she's still here. But I'll get back to you in terms of that question. Any other questions in terms of IMT specific questions? But yeah, so are you definitely set on cardiology then?
Yeah, so right from the beginning, so it's like second year medical school.
Oh, fantastic. Fantastic. Okay.
I think there's something in the chat there about the GIM.
Oh yeah, I think that's from a cardiology registrar.
Yeah, it is. I think the trainees I work with now, I'm doing a cardiology job. They're not on the GIM motor, but I'm in a tertiary centre, so that's probably why I've based that.
Amazing. Okay, guys, if you have any other questions, otherwise we will wrap it up. Please do fill out your feedback forms, because then you can get the A certificate of attendance. And we can wrap up. I'll give you a couple more minutes. Okay. So okay, so you got a thank you comment. Thank you very much. But I think your talk was just so comprehensive that there's no specific IMT questions. But you are right in terms of the competition ratios have spiked so much over the past year. I know quite a few people that didn't get IMT at all.
Yeah, so before that, I genuinely quite arrogantly in medical school would think everyone can get an IMT job, but it's because so many people have started going into it now, especially because of COVID. People haven't been able to travel as much as they can, so everyone applied at the same time. There's been a spike, but it's interesting to see if next year would be a similar level of competition.
I think so too. I don't think we're going back down. I think this is just a new norm, and that people just need to get ahead of the game. Okay, guys, I'm going to give you just one more minute if there's any other questions. Otherwise, you can wrap it up. Okay, one question that we've got here is that, is infectious diseases a dual speciality? Is it a part of the group 1?
It can be. So on its own, it would be a group 1 specialty, but quite often people do it dual training with, say, medical microbiology or virology, in which case it's a group 2 specialty.
Okay, great. So you can kind of, it fits into both, but it just depends on what you add together, is it?
Yeah.
Okay. Someone has asked you how are you preparing to deal with the med-reg life, that they've had quite a lot of horror stories about it?
I mean, I was always kind of a weird F1. I used to prefer night shifts where people left me alone to look after sickies and stuff. So I'm actually I can't wait for the responsibility. I kind of want to be a med-reg, kind of like walk in the middle and going, this is my hospital, I'm in charge now.
That is a fantastic response. That's a fantastic response. So you're basically ready for it. There isn't anything.
Yeah, I'm just waiting for them to let me do it, basically. No, all seriousness, you have to practice reviewing sick patients and coming up with a plan. And once you've done that and you've gone through all your training and taken the teaching a bit more seriously, you should have the skills. You just need to be brave enough to put them in place, basically put them into practice. I mean, that's what I'm banking on.
Amazing. So another question that we have is, what do you find to be the most challenging part of IMT?
The portfolio is a nuisance sometimes. It's because of COVID, we didn't have much of an introduction. They put a few slides on a shared drive, and we were expected to go through them all. So you have to go through a lot of things. You need to get very specific stuff that you'll need to get signed off and things of that nature. But the actual day-to-day job is quite nice. If you're on a nice ward with a nice consultant, a nice registrar, you'll enjoy it a lot. You'll learn a lot, because medics tend to do proper long ward rounds. So they'll they'll take the time out to teach you about anything that's going on. You'll get to review patients, and really you'll get to just be a doctor. So that's the nicest part. The online portfolio tick boxing stuff is it's a pet peeve of mine, but you just have to get over it.
Yeah, I think it's just something, I don't think we'll get away, honestly, forever for our careers. And someone just said that you had a really great response to the MedReg questions. Nothing like that. Excellent.
I think I've got a question in the chat there. I'm not, it says privately though. Should I answer that? Okay.
Yeah, I mean, go for it.
Fine. Okay. Any other questions then? In the meantime?
I can't see any other questions, guys. I'm just going to give it another 10 more seconds, and then otherwise we can wrap it up. Let me just double check. No other questions. Guys, if you just fill out the feedback forms, as you know, commitment to speciality is very, very important. You'll get certificates of attendance from us as well, for being keen and spending your evening with us. But yes, I think that's it really. Dr. Drew, thank you so much. I'm going to stop the recording now.